Good morning to one and all. Welcoming you all to the fourth presentation of basic module in infectious diseases, cycle 2. So myself, I'm Swadhya Saman, FCPI forum member, infectious diseases, and the topic for the day is I hope it is audible now.
Yes, you are audible now.
So myself, I'm Swadhya Saman, FCPI Infectious Diseases Forum member, and the topic for the day is penetration of antibiotics to different body sites. So, madam, can you move to the next slide? So now moving on with the participant guidelines. So you can post your questions, type your questions or responses in the comment box and click the submit button. Your questions will be discussed during the Q&A session towards the end. You can submit your feedback. So feedback button will be available below the comment box and feedback form will be disabled after the live session. You can claim your certificates. So certificates of the attendees will be issued within 14 days after attending of the event. So if you're watching the event on YouTube, please log into our website and register for the event to claim your certificates. And you can also download the presentation. So the presentation slides can be downloaded, but a login is mandatory to download the file. So now introducing the speaker of the day. So now we have with us Dr. Surabhi S. Dupad. She's a PharmD graduate. She's working as clinical pharmacologist in Dinanand Mangleshkar Hospital and a research center. So over to you, madam.
Thank you, Swati. So let's move in toward our today's presentation of the topic is penetration of antibiotic to the different body sites. And good morning, everyone. So there is no disclosure from my side. So what we are going to learn from today's presentation are number one is to learn about the factors affecting the tissue penetration. That is the factors which are most important for the penetration of the antibiotic to the different body sites. Then number two, to know the importance of the tissue penetration, forming the appropriate dosing regimen. As we know that as we know the appropriate dosing regimen is very important. So making this knowledge to participating and forming the appropriate dosing regimen. Number three, to improving our pharmacokinetics and pharmacodynamic knowledge about the drug. And for the efficacious dosing regimen, as there is increase in resistance and decrease in susceptibility, which is leading to the failure. And number four is none but the practical approach. That is, it is a case-based presentation. So moving towards our first question, that is, what is exactly the antibiotic penetration means? And why do we need to know the antibiotic penetration at the different body sites? You can answer in a chat box or in a comment section. So Swati can let me know about your answers. Is it okay, Swati? Am I audible?
Yes, yes.
Okay. So moving towards our options for the question number one. So the antibiotic penetration is nothing but the extent to which the antibiotic reaches the infected tissue, or the concentration of the antibiotic at the site of infection is known as our penetration of antibiotic at the site of infection. So as we all know that E. coli is the common pathogen we found in our gut and causing pathogen, that is UTI. So, but We also know that E. coli can found in any part of the body, such as in the blood, that is causing the bacteremia, in the liver or in the pancreas, causing the abscesses such as liver abscesses, cholangitis, that is pancreatic abscesses. So it's important to know the antibiotic reaching to the liver, to the pancreas, or to the blood. So we can formulate a proper dosing regimen depending upon the antibiotic reaching the site of infection. An outcome is totally depend upon the concentration of that drug at the infected body site. So this is an overview. This is a diagram for overview that we are seeing in the presentation today. So depending upon the sites, we are going to see the different drugs reaching to the site of the infection in the body. Okay, so what are the important factors that affects your tissue penetration? So the options are drug characteristics, vascularization of targeted organ. Number three, presence and absence of the inflammation or all of above. So you can put your answers in a chat box so I can see that. So answer to this question is all of above. So drug characteristics, vascularization of the targeted organ, presence and absence of the inflammation. These all are the factors that are important for your tissue penetration. So we are going to discuss each one of the characteristics. So first is drug characteristics. So drug characteristics, which are the most common drug characteristics and which are the important drug characteristics, we are going to know about the drug penetration. So first characteristics is the molecular size. Molecular size of the drug is very important for the penetration. So lower the molecular size, your penetration is a good penetration or the better penetration. So as the size is low, it occurs or it covers the larger surface area. So better penetration depending upon your size. Then second characteristics is your lipophilicity. Is the drug is lipophilic or hydrophilic is very important characteristics for the penetration. So the more the lipophilic drug, more is the penetration. So because we all know our cell membrane is made up of lipoproteins and glycoproteins. So more lipophilic drug, it will easily cross your cell membrane and penetrate into the tissue. And number three, but not the least, is protein binding. Protein binding is very important characteristics for the tissue penetration. So less the protein bound drug, more the penetration. As if the protein binding is more, there is the less free drug available in your blood to reaching that infection site. So more protein binding, less penetration. Less protein binding, your penetration is good at the site of infection. Number two, our targeted tissue characteristic, that is the vascularization of your targeted organ. What is meant by the vascularization? Actually, the blood supply or capillaries that they supply blood to that organ. More capillaries, more vascularization, more drug is available to penetrate at that organ or travel through the blood to that organ. So vascularization increases your penetration. So more the vascularization of the targeted organ, there is the tissue penetration is good. Now third is presence and absence of inflammation. Why the inflammation is important in the penetration? Because acute inflammation causing or acute inflammation at the injury site is important as it increases the absorption of the drug at the targeted organ. Basically, it increases the exposure of the drug at the particular site, and it is mainly for the drugs which are metabolized by cytochrome P450. And it is not, that is it, when the inflammation is there, it is going to increase the penetration of drugs which are going to metabolize by your cytochrome P450. But it is opposite for the drugs who are going to metabolize or excreted by your glomerular filtration tract. So these are the three characteristics which are important for your penetration of antibiotics. For the agents with the wide therapeutic range, mainly with the ratio of serum concentration is small, increase the systemic doses will increase your tissue penetration or the concentration, like beta-lactam antibiotics. Wide the therapeutic range, and as we increase the concentration or as we increase the dose, you can reach to the system where the beta-lactams cannot reach. So this is the second diagram depicting how the drug travel to the tissue from the blood. So the drug which is in the unbound state travel to the interstitial fluid and then finally into the tissue state. But the drug which is in the bound state get convert into unbound state and then travel to the tissue penetration. So protein binding is important. Now, antibiotic penetration at the different body sites. So we are going to see the sites one by one. So we are going to see the central nervous system, eyes, then lungs, then bone and joints, biliary system, prostate, and last is urinary system. So moving towards our first system, that is central nervous system. So as we all know, the central nervous system has the barrier for the drug is known as the blood-brain barrier. So blood-brain barrier is the main obstacle for the drug for penetration of drug into the CNS or cerebrospinal fluid. And there are two ways by which the drug travel through the blood-brain barrier into the CNS or the CSF. Number one is passive diffusion and number two is active transport. Passive diffusion is depends upon totally a drug characteristics, but the active transport is depends upon the permeability or the effectiveness of your glycoproteins are the transporters present on the blood-brain barrier, such as PGP, that is glycoprotein, then organic anion transporters, and peptide transporter. So, the drug which are enabled to bind to that transporter, so these are easily passed to the CNS from the blood-brain barrier. So, moving towards our first case, so a 61-year-old male which is admitted with intermittent fever spikes, his known case of hypertension and coronary artery disease, and he has multiple admissions. He has multiple admissions for pulmonary infection, but no pathogen were isolated during his stay. Now, he had intermittent cough with a fever spikes, night sweats, and hemoptysis for past 1 year. So he got admitted with the complaints of fever, cough, night sweat since 1 year. Now on admission, we done the CT and we shows the bilateral lung infiltrate lesions, bronchiectasis, emphysema bullae, and right pleural effusion. So you can see in the right lung, the emphysematous bullae of lung and a minimal right-sided pleural effusion. So this is the CT chest of the patient. Now he was started empirically on cefoperazone sulbactam. While on cefoperazone sulbactam, the patient's symptoms were improved, but the neurological symptoms were worsened, such as headache, delirium, memory loss appeared. Now, MRI brain was performed on that patient and which suggestive of left frontal lobe lesion around 35 by 55 mm considered as abscesses. While draining the abscess, CT-guided aspiration were done and the abscess was sent for testing, such as culture. And culture had grown the nocardia farcinica. What would you choose to treat him with and why? So, options are sulfamethoxazole trimethoprim, that is Bactrim DS or Ceftran, Ceftran plus imipenem cilastin, Ceftran plus amikacin, or combination of Ceftran, amikacin, and imipenem cilastin. So these are your options, and you can answer me in a comment box. And Swati, please let me know if there are any answers from the students or any one of them.
Sure, Dr. Surabhi. Yeah.
So these are the options. So we are going to see the drug of choice for nocardia facinica, brain abscesses mainly, because MRI brain shows the abscess which we are drained, and we found that nocardia facinica in that abscess. So moving towards the answer for the question is the combination of ceftriaxone plus amikacin plus imipenem-cilastatin. So why the combination? Because ceftriaxone is the drug of choice for nocardia CNS infection because it has the good penetration in the CNS. But as we can see, the CT of chest also have developed the emphysema of bullae of the lung. So it is a disseminated infection to the different organs. So we are going to add the amikacin in addition with imipenem, that is combination of 3 drugs for disseminated nocardia infection. So this is your answer. Moving towards the chart, these are the charts for the penetration, CNS penetration of antibiotics of the drugs. Okay. Now summarizing these charts, so penetration of the drugs which are good CNS penetration, the drugs which are having a good CNS penetration are linezolid, metronidazole, fosfomycin, rifampicin, ceftriaxone that we are seeing, sulfamethoxazole and trimethoprim, fluoroquinolones, chloramphenicol. These have the good CNS penetration, followed by the glycopeptides that are vancomycin, daptomycin have the good CNS penetration. Following the carbapenems, that is meropenem, imipenem, have the better CNS penetration. Then third generation cephalosporins and your penicillins have the better CNS penetration. So moving towards our second system, that is your eye. So mainly intravitreal antibiotics and vitrectomy are the mainstay of the treatment of management of endophthalmitis. Basically, endophthalmitis and retinitis are the common infections which are going to happen with your eye. So post-operative or without a surgery, the endophthalmitis and retinitis are the main infection causing your eye. And intravitreal antibiotics are the mainstream of your endophthalmitis treatment, including with vitrectomy. So, for which we are going to discuss about the intravitreal injections and the drug which have the good penetration in your vitreous, humor, as well as the anterior eye. So factors which influences your penetration into vitreous basically depends upon the two factors or the two parameters. Number one, distribution of your drugs into the vitreous and elimination of your drug from the vitreous. So these are the two parameters which influences your penetration of the antibiotics from the eye. So first is the distribution of the antibiotic in the vitreous. So distribution of the antibiotic in the vitreous is depending upon the further three factors. Number one, your drug characteristics, that is the molecular size of your drug. It is important, as we discussed previously. Number second, influence of your vitreous convection, that is the flow of your vitreous also have an effect on your drug. So increasing in the flow, there is decrease in the penetration. So stable the flow, increasing in your penetration. And number third is interaction of the drugs with the components in your vitreous. So there are different components in your vitreous humor. So as well as it includes the proteins. So when the drug get bound to that proteins which are already present in your vitreous, so there is a decrease in your distribution of the drug and it lowers the process and decreases your penetration. So it's gonna affect the penetration of the drug when it get bound to the components which are present in your vitreous humor. And second is the elimination of your drugs. Elimination of your drugs is depending upon the state of inflammation and the surgical status. So if there is an inflammation, there is the increasing penetration as we discussed previously. And second is the surgical status. So clearance is more rapid in aphakic eye. If there is vitrectomy done, the clearance is more rapid in the aphakic eye, that is absence in the vitreous. But in the presence of the vitreous, penetration is good, clearance is less. So we are going to moving towards our case 2 related to our second system, that is eye. So a patient with 69-year-old male retired chemist by occupation having a diabetes and which for which he is on metformin awoke with a severe eye pain and decreased the eyesight in a left eye, presented to the ER a few hours later. So a 69-year-old male, he is a chemist by occupation and awoke with a severe pain in eye and decreased in a vision. He's coming towards ER a few hours later. His eye had been feeling well after undergoing the cataract extraction surgery of left eye 2 days prior until this morning, and right eye surgery 2 months back. So he got a surgery 2 months back for a right eye and for 2 days prior for the left eye. Now he is coming in the ER with the eye pain after the surgery of the left eye. So bright light seems to make a pain worse and vision seems very foggy with a lots of floaters. The patient denies any fever and chills. No complaint with the right eye, no the diabetic eye disease history, no not any trauma to the left eye, diagnosed as post-operative endophthalmitis as there is a surgery 2 days prior. So vitreous culture which had grown a your Staphylococcus epidermidis. So what would you choose to treat him with and what you need to know before treating the patient? So now in your vitreous, you are having the Staphylococcus epidermidis. So what it is an organism? It is a gram-positive bacteria. So what you need to know before treating the patients? So number one, it is a MRSA or MSSA. That is methicillin sensitive Staphylococcus aureus or methicillin resistant Staphylococcus aureus, and intravitreal antibiotic choices. As we have seen in the earlier slides, vitrectomy and intravitreal antibiotics are the mainstay for endophthalmitis. So now we diagnose this patient as post-operative endophthalmitis. We have to know the intravitreal antibiotic choices. So this is the susceptibility report. So is it MSSA or MRSA? Can you see? So cloxacillin is resistance from which we can differentiate it is a MRSA drug or MSSA drug. So as the cloxacillin is resistance, it is a MRSA. Staph epidermidis is MRSA staph. Okay. So drug of choices or susceptibility to the susceptibility of the drug for the organism is vancomycin, teicoplanin, linezolid, doxycycline, and Bactrim. So commonly used intravitreal drug in bacterial endophthalmitis are vancomycin, vancomycin plus ceftazidime, and amikacin. But amikacin we are not using nowadays because of its retinal toxicity. So options are vancomycin, vancomycin plus ceftazidime. Now this is the chart of antibiotics which have a good penetration in your eye. But most commonly, we use intravitreal vancomycin, ceftazidime. But these drugs also have a better concentration depending upon your surgical eye status and a single dose after a single dose penetration. So we can move toward our third system, that is lungs. I hope you are understanding and understood well the previous two systems and the penetration of the antibiotics at those systems. So let's move towards our third system, that is lung. So pulmonary infection mainly begins with the inner part of lungs, that is the air space. Thus, the antibiotic concentration within the air space is direct importance. So, infection to the lungs are mainly starts with the inner part of the lungs, that is your alveolus or bronchioles. So, penetration at your parenchyma of the lung is very much important. So, inner part of lung is mainly covered by your epithelial lining known as ELF, epithelial lining fluid. ELF is a natural barrier for your pathogens, but also medium by which the pathogens multiply and enters your lungs. So inner part is alveolar lining includes your alveolar lining fluid or interstitial fluid. Okay, so your barrier composed of two membranes, that is alveolar wall and capillary walls. So capillary walls contains the penetration and allows the free diffusion of smaller molecules from bloodstream to the interstitial fluid. Alveolar wall does not have the penetration to facilitate diffusion from interstitial fluid to the inner lungs. So the antibiotic passes through the alveolar epithelial cells in order to reach your ELF. Lipophilic agents have higher distribution in ELF, where the hydrophilic agents have the lower distribution in ELF. So that your lipophilic drug can easily accumulate in your lung or have a good penetration in your lungs, while your hydrophilic drug have a lesser penetration in your lungs. So coming back to our third case, that is 55-year-old man who transferred to the hospital after having a stroke. He had prolonged hospitalization at outside hospital. His record mentioned the history of Klebsiella pneumoniae isolated from the sputum. He completed the treatment for that Klebsiella pneumoniae with the meropenem. Now, he is admitted with fever on arrival and has thick purulent oral secretions. His chest X-ray shows bilateral lung infiltrates. His blood and sputum culture were taken and patient was started on IV polymyxin. Why we are starting him on IV polymyxin? As he has already had a Klebsiella in his sputum culture, for which he already had treated with meropenem. Now, further he had growing spikes and have a thick purulent secretion already treated with meropenem. So it's going to be a CRE, that is carbapenem resistant bug. So we are going to start him with the IV polymyxin. Now, sputum culture report came and which had grown your Klebsiella pneumoniae again with Acinetobacter. Blood culture also gave your Klebsiella pneumoniae and susceptibility reports are here. So Acinetobacter, which is CRE and only sensitive to your minocycline, as well as your Klebsiella pneumoniae, which is also CRE and only sensitive to your minocycline, as well as for azithromycin and doxycycline. So what are your options for treating the patient with? So number one, continue IV polymyxin monotherapy. Number two, minocycline monotherapy as both bugs are sensitive to minocycline. Number three, combination of polymyxin and minocycline for treating these organisms. And number four, ceftazidime avibactam plus astrium. So what are your options for treating these organisms? Please comment, please give your answers in a chat box so I can know if you're attending properly or not. So 4 options are here for treating the organism. So what you need to know, seeing these reports and knowing these options. So what you need
Dr.
to know.
Surabhi, may I
Yes.
interrupt in between? So there is someone who voted for number three, option number three.
Okay. Combination of polymyxin and minocycline.
That is Dr. Bhuvaneshwara.
Okay. Thank you for your response. So what we are going to see and what we need to know about, or before knowing the before knowing sorry, after knowing the susceptibility report. So number one is polymyxin or colistin amices. So Dr. Bhuvneshwara, your answer is actually right, but we need to know the colistin amices before treating the organism. So colistin amices, this is the report showing the colistin amices for both the organism. So Acinetobacter have colistin amices in between 4 and 1, that is more than 2 but less than 4. And for Klebsiella pneumoniae, it is less than 1. So can we use the polymyxin for Acinetobacter, or we can use the polymyxin plus minocycline combination therapy for Klebsiella? So colistin amices are very important for treating the patient. And number two, the synergy of Zavicefta aztreonam, that is ceftazidime avibactam plus aztreonam synergy for treating this patient. So it is important to know before treating the patient the MICs of colistin and synergy of your Casavi aztreonam. So your answer is right. We can treat this patient with combination therapy of polymyxin and minocycline, as well as it is in the sputum, so we can give the colistin names. So moving towards the penetration of the antibiotics in the lungs. So as we can see, penicillins have not much but a better penetration in the lungs. Daptomycin does not have any penetration in the lungs. It is exception because it get destroyed by the surfactants in the lungs. Fluoroquinolones have a good lung penetration. Mainly the lipophilic drugs have good lung penetration than the hydrophilic drugs. So moving towards our fourth side, that is bone and the joints. So it is very complex to know your bones and joints, because bone and joint infection are the major health problems and considered as a significant cause of morbidity and mortality. Moreover, the treatments are also challenging and requires the prolonged courses and hospital stays if there is bone and joint or bone and joint infections. A bone is a less vascularized tissue. As we know, bone is the organ with the less blood supply. It is a less vascularized tissue and it has a less blood supply. So the bone penetration of antibiotics are really challenging. So we are going to discuss a little bit about the bone structure. So bone tissue consists of the organic fraction and inorganic fraction. So 35 to 40% it's an organic fraction and remaining 70% it is an inorganic fraction. The organic fraction or organic matter basically consists of your collagen fibers. That is your glycoproteins, then proteoglycans and extracellular fluid. Bone cells which only present in 1 to 2% of total bone mass. So cells are very less in the bone. Inorganic matrix which consist of your S, calcium phosphate, then hydroxyapatite crystals, etc. These are all your inorganic matrix. Basically, we are going to learn about your organic matrix. So this is the overview of the structure of your bone, and we are going to see how the antibiotic reaches to the capillaries and reaches to the organic matter of the bone. In normal, the bone Water-soluble minerals leave the capillaries by the passive diffusion depending upon the molecular weight of the molecule. Fat-soluble molecules, however, passes freely through the capillary walls and reaches to the bone parenchyma or the bone matrix. Once outside the capillaries in the bones, there is a fluid space. This space separates the vessels from the bone cells and the collagen and the hydroxyapatite. Antibiotic penetration at the capillary level is mainly dependent upon the fat solubility, molecular size, protein binding, and the partition coefficient and the pH of the solution. So in the acute osteomyelitis, there is general increase in the blood flow or increase in the blood supply to the bone by the capillaries. So there is a permeable concentration of the antibiotic is greater. In other hand, for the chronic osteomyelitis, it is the infection from years to years and ongoing. So there is a blockage to the antibiotic penetration as there is a dead tissue or the chronicity is there. So it affects or it obstructs your antibiotic penetration at the bone matrix. So moving towards our case number 4, that is a 37-year-old male, a case of RTA, that is road traffic accident, operated outside for a acetabular fracture with a head disruption in a July 2023. So a 37-year-old male, which 37-year-old male, he had already operated outside for the acetabular fracture with the head disruption, came to the hospital for the surgical site pain, swelling, and discharge from the site. So diagnosed as surgical site infection and planned two-stage surgery. So basically, if there is a prosthetic joint infection or a surgery, then it is going to divide into your one-stage surgery or two-stage surgery. One-stage surgery is going to be happen once the patient is open, remove the previous implants and put back the new implants in a one step. And second stage surgery includes that two-stage surgery includes your explantation of your implant, then a gap for minimum 4 weeks, then reimplantation of the new implant to the body. So these are the two types of surgery, that is one stage surgery and two stage surgery. Stage 1 implant removal and the stimulation of application done and debridement samples sent for the investigation. So patient have gone for the first stage, that is implant were removed from the bone, then tissue were debrided as well as the pus culture were sent for the investigation and the wound is gonna closed. So now the tissue culture sent and the pus culture sent for the sampling grown Enterobacter hormoshae. Enterobacter hormoshae is a gram-negative bacilli basically, and it found to be a ESBL, that is extended spectrum beta-lactamyces. Now susceptibility, we are going to see the Enterobacter hormoshae, which is susceptible to your piperacillin tazobactam, then aminoglycosides, then fluoroquinolones, that is your ciprofloxacillin, levofloxacillin, then Bactrim DS, TMP or TMP SMX, susceptible to your cefoperazone sulbactam, meropenem, imipenem, ertapenem, minocycline, and fosfomycin. As we all know, it is an ESBL organism, so it is going to destroy your penicillins and cephalosporins, mainly the first generation, second generation, and third generation cephalosporins are destroyed, and carbapenems are the drug of choice when there is gram-negative ESBL organism. So the patient was started on meropenem, planned for minimum 4 to 6 weeks of meropenem, with follow-up with ESR-CRP. So patient gradually improved on meropenem and did well. So here we have to know, does the meropenem penetrates well to the bone or not? So meropenem have the better bone penetration as we are giving meropenem in the higher doses and for longer duration. So meropenem will work good for this bacteria as well as for the bone. So this is the bone that is matrix as well as joint penetration of the drugs. Basically, peptides has good penetration. That means basically in peptides, the piperacillin has good penetration in the cancellous bone as well as cortical bone as well as in joints. Flucloxacillin and cloxacillin have penetration in the bones but not in joints. But when you are giving it through the IV, not the oral, have the good option because oral antibiotic does not reaches your bones and as well as joints. So meropenem have good penetration in bone as well as in joints. You can see daptomycin has good penetration, vancomycin has good penetration, dalbavancin has good penetration in the bone but not in joints, otrivavancin, the newer drugs have good penetration. Then Bactrim DS also have good penetration in joints. Rifampicin has good penetration, but it can be only used in a oral suppressive therapy while with the combination, not alone. So moving towards our fifth system, that is your biliary tract. So biliary tract infection mainly includes your cholangitis and cholecystitis. It also includes your lobes in the liver, which uh, follows or which includes your drainage and transport or your bile, basically bile. So transport system of your bile is known as your biliary duct system, so, or biliary tract. So basically biliary tract infection mainly includes your cholecystitis and cholangitis, but it can also include your liver abscesses, cholangitic abscesses as well. The gram-negative Enterobacteriaceae make up for majority of your biliary tract infection, and the two most common organisms which causes the biliary tract infection are your E. coli and Klebsiella. In the other hand, the most common organisms which can also found in the biliary tract are the Enterobacter and Streptococci, the gram-positive bacteria or gram-positive cocci. Then Clostridium species and Bacteroid species, which are the anaerobes, also have found in your biliary tract. Okay, so moving towards the penetration of antibiotics in your biliary tract. So antibiotics such as your amoxicillin, cefoxitin, ertapenem, gentamicin, amikacin, and TMP-SMX had the poor biliary penetration. Except all these antibiotics have the good biliary penetration. The main 7 antibiotics which have the poor biliary penetration are amoxicillin, cefadroxil, cefoxitin, ertapenem, gentamicin, amikacin, and your Bactrim DS. Bactrim DS is the drug which have the good body and tissue penetration except your biliary tract. The 3 antibiotics such as ceftolozane, tazobactam, doripenem, and ceftibuten had a positive clinical outcome despite of lack of pharmacokinetic studies because these are the drugs not studied in India. So these have the better penetration in the biliary tract. Effective antibiotic treatments for biliary tract infection based upon basically antimicrobial spectrum of the organism and the susceptibility report. So factors influencing your biliary tract penetration is again the hydrophilicity of the drug, hepatic metabolism, plasma and hepatic transport, protein binding, and molecular weight. So these are the chart of the drugs showing the biliary penetration. So cefuroxime and ceftriaxone have the good biliary penetration. Levofloxacin, ciprofloxacin, moderate biliary penetration. And moving towards our next point or next system, that is your prostate. Drug penetration into the prostate or prostate gland is thought to be governed by the principles determining the drug passage across the lipid containing membrane. Basically, all the tissue penetration is governed by the penetration to the site through your lipid bilateral membrane. So same for the prostate, the principle for determining the drug passage entering into the prostate is governed by your lipid containing membrane. transports. In the presence of the secretory and active transports, the drug penetration is presumably passive. So passive transport is mainly, which is the passive transport is mainly important in the transport of the drug to the prostate, consisting of diffusion and the concentration. The factors or the characteristics which are influencing the penetration of the drugs into prostatic fluid and prostatic tissue are lipid solubility, dissociation constant, and the protein binding. So this is the diagram depicting the membrane of the prostate and pH of the prostate, which is mainly important for the drug penetration into the prostate by the lipid bilayer. So lipid solubility, degree of ionization, protein binding, and molecular size is important for the penetration of antibiotic into the prostate. So prostatic penetration, prostatic tissue penetration as well as the fluid penetration. The cefuroxime, amoxicillin, that is your penicillins and cephalosporins have the tissue penetration but not the prostatic fluid penetration. But azithromycin have the fluid penetration, not tissue penetration. So basically the drugs which are lipophilic have the good tissue penetration but not a fluid penetration. For fluid penetration, the drug must be amphiphilic or slightly hydrophilic. Moving towards our last system, that is urinary system. So antibiotic treatment for the urinary tract infections or the UTI is basically depend upon the antibiotic being able to inhibit the growth or kill the bacteria present in the urinary tract. So for the treatment of urinary tract infection, your drug need to kill that bacteria in the system. So pharmacokinetics of the antibiotics in urinary tract includes the kidney, bladder, and your prostate. So infection to your prostate, that is prostatitis, cystitis, or pyelonephritis, complicated and uncomplicated. These are all the infection need to be treated with the bacteria, and for which we need to learn about the pharmacokinetics of the antibiotics at the different sites and different parts of your urinary tract. Urinary drug concentration mainly depends upon the serum levels of your drug, percentage of the drug excreted in the urine, and how the concentrated the urine is. So the urinary concentration is mainly depend upon the three factors, that is serum concentration of your drug, then the percentage of the drug excreted in the urine, and the percentage of the drug achieved or concentration achieved in the urine. So now the case is 70-year-old male with a CLD came with a dysuria and pain in the lower abdomen. So urine routine showed that 300% positive leukocyte esterase and nitrate, which are the main markers we can see for the bacterial infection. USG of that patient had done, and which shows the suspicion of emphysematous pyelonephritis. So for which confirming we have done the CTKUB, which shows the class 1 emphysematous pyelonephritis with mild hydronephrosis. So patient was empirically started on meropenem, urology reference taken for underwent urology reference for taken for degestanting. The patient underwent for degestanting. Now we have done the urine culture, but we have flagged the border for blood culture, and we shows the gram-negative bacilli is growing in your blood. So before knowing the susceptibility report, after 3 to 4 days, we have our sepsis flow, which get the result in just 4 hours. So we have done the sepsis flow on the blood, which shown the organism E. coli. We showed the organism E. coli with the resistance markers CTXM, NDM, and SH. We have already learned this in the presentation of Saidulu sir. So E. coli is growing in the blood with the markers of CTXM, NDM, and SHV. That is, it is going to be a carbapenem resistant E. coli. Now, as we are knowing the sepsis flow, the patient is now started on Zavicefta aztreonam. synergy, but synergy is not detected. Now, what are your options? E. coli in the urine, E. coli in the blood with the carbapenem resistant markers. Presently, we are started the patient with the meropenem. Now, knowing it is a carbapenem resistant bug, we have started him on Zavicefta astronome, but the synergy not detected. Now, what are your options? So, your options are polymyxin plus minocycline monotherapy, combination therapy, then IV colistin, then fosfomycin. These are the options for you. So the carbapenem resistant E. coli with synergy not detected mainly have the PBP3 mutations, and we have emerging resistance for the Zavicefta astronome synergy, and we have emerging resistance for this combination therapy. So we are going to treat the patient with combination therapy of colistin or polymyxin fosfomycin. So patient was started on colistin, that is IV colistin, and fosfomycin, IV fosfomycin higher doses. IV therapy, combination therapy, then patient clinically improved, was given for 3 weeks of therapy, then underwent stent removal. Patient is better and discharged home. So this is the paper. The combination of colistin and fosfomycin have the synergistic against the NDM1 producing enterobacteria, have the in vitro pharmacokinetic and pharmacodynamic model experiment. So this is the paper which suggests the combination therapy of colistin and fosfomycin for the E. coli, which is carbapenem resistance, as well as in which the synergy of Zavicefta astronome is not detected, or mutated PBP3 in E. coli. So learning points from this case is importance to verify your colistinemesis, then Zavicefta astronome synergy. If synergy is not detected, then what are your options, as the CRE resistance for Zavicefta astronome is emerging. And these are the antibiotic with the penetration in your urinary tract. So penicillin G has the good penetration, amoxicillin has the good penetration, cefazolin has the good penetration. Then your fluoroquinolones have the good penetration. Minocycline has the good penetration. Fosfomycin also has good penetration. DMPSMX has good penetration. Piperacillin has good penetration. So these are the references for the papers from which I have taken the information. These are the references. Upcoming lecture on 8th May and 10th May. Thank you.
Dr. Surabhi, the session was really informative. So moving on with the questions. So on the YouTube live, there are no questions that has been posted, but I would like to have a few questions and interactions with you. So one of the queries that I wanted to ask you is that in certain cases where we get a CRE from the brain, or in certain cases, if there is a brain abscess and there is a CRE, and if we are going with ceftazidime avibactam, and as you were saying that in a case where we are not able to check on with the synergy, do you recommend if we are choosing for meropenem plus colistin or polymyxin therapies for longer durations?
Yes, we can use the intrathecal colistin in such patients, as well as meropenem in higher doses for such patients. We can use the meropenem with a combination with the IV polymyxin, intrathecal colistin, as well as with the other agent. So monotherapy is not recommended, but combination therapy with meropenem, polymyxin, as well as minocycline is recommended for such cases.
Okay, Dr. Surabhi, thank you for that clarification. So intrathecal in that cases would be more effective, right?
Yes, true.
Yes, yes. And one more question that I wanted to address is we're talking about the fosfomycin injections. So in the practical setting, as we know that the fosfomycin injections are quite expensive, can we use the same kind of a strategy in places where there is an E. coli in UTI and if there is a financial difficulty for the patient and we can't go for a fosfomycin IV injections? Can we, I mean, how can we tackle such situations?
Actually, in Maharashtra, it is not that much inexpensive. Actually, fosfomycin is inexpensive, but if it is an uncomplicated UTI, IV injection is not affordable for patient. You can go with the oral fosfomycin for 3 doses, or even it is not that much complicated. You can use oral fosfomycin for 5 to 7 doses for pyelonephritis as well. So it is much cheaper than IV fosfomycin therapy.
Okay, okay. So one more concern that is like when we are going for the higher doses, what precautions can we take regarding the ADRs or and if the patient is having any difficult situation where we are supposed to adjust the doses. So in such cases, should we go with the higher dose itself for the penetration to be good?
So basically, what we are saying, the levels are the good markers, basically. But for the drugs, we are not going to monitor the levels, for which we are going to assess the patient for the side effects, and then we can use the higher doses of the drugs, basically. So for the patients, we are going to use higher doses. Basically, for the drugs, we have the levels for the patient, that is your drug levels. So we can do the drug levels for the patient. If we are not going to the drug levels, then we can moderate for the side effects and inform the patient for the side effects, or the patient is not in that condition, it is the ICU patient. So we can monitor the side by side the side effects. If the side effects, we are not going to use the higher doses.
Okay, Dr. Surabhi, thank you for the clarification and hope we'll end the session soon.
Thank you. Thank you so
Yes,
much.
yes.